Bonjour, nous allons commencer ce symposium sur l'immunothérapie. J'ai l'honneur de vous présenter le professeur Pascal Demoli. Je l'ai connu depuis qu'il était interne des hôpitaux de Montpellier au service. Il a grimpé dans l'allergologie pour devenir un des piliers de l'allergologie mondiale. Il est professeur de pneumologie et allergologie à l'hôpital de Montpellier, chef de service au département de pneumoallergologie à l'hôpital universitaire de Montpellier. Il était président de la Société française d'allergologie 2010-2012, vice-président actuel de l'Académie européenne d'allergologie et bien sûr, il est titulaire de centaines de publications internationales. À toi, Pascal.
Merci, Annan. Dear colleagues, I've been told to speak in English. For the non-French-speaking colleagues, I would first like to thank you very much for the invitation. Thank the organizers of the meeting, Dr. Hayat and Dr. Irani. Thank you, Annan, good friend for 30 years, no, almost. And thank you to Allergen to give me the opportunity to stimulate you a little bit about allergen immunotherapy. As you know, allergen immunotherapy was introduced by a clinician, Dr. Noon and Freeman, coming back from Institut Pasteur in 1911. So we have now passed 100 plus 2 years with allergen immunotherapy around. And as you know, allergen immunotherapy has been built on personal beliefs and empirism, which automatically prompted the appearance of false beliefs concerning everything, its efficacy, onset of action, and administration regimens. That is why we have so many people in the world not believing in immunotherapy. But these false beliefs have often been ingrained in the brain of non-allergist doctors and unfortunately also in some deciders' mind. However, over the last 20 years, there have been many clinical studies which have validated allergen immunotherapy efficacy and safety, and the regulatory agencies now consider allergen immunotherapy as a full pharmaceutical specialty, and this is really the creation of a new therapeutic class. And these are several of the dogmas or false beliefs or misconceptions or fallacies, you call them whatever you want. And I'm going to pick up 6 of them and go into detail. Okay, the first one is that there is no need for allergen immunotherapy, that you have enough drugs to treat all the respiratory diseases. And I think it's wrong, but we will talk about that. The second one is that allergen immunotherapy has never been tested properly. There are many doctors thinking that these have never been tested. This is wrong as well. Allergen immunotherapy is less effective than pharmacotherapy. I will show you data on that. That is wrong as well. Allergen immunotherapy must be taken several years before being efficacious. Is wrong as well. You'll see that the onset of action is rather fast. Dogma 5, allergen immunotherapy does not work in polysensitized patients, only work in very selective monosensitized patients. This is wrong as well. You'll see the data. And for those of you who are using subcutaneous immunotherapy, although I don't want to oppose those two, there are many doctors thinking that subcutaneous immunotherapy leads to better compliance compared to sublingual immunotherapy. Okay, let's take the first dogma. And I'm going to take the example of allergic rhinitis because this is the one which has been developed most. But I will talk a little bit about asthma, but I hope that you're going to have questions about asthma afterwards. So the first thing we read and hear about often is that allergic rhinitis is a trivial and homogeneous disease. Okay, so let's take the example of several surveys. I take the one we performed in France. 14% of the French population, which means 8.8 million people, suffer from hay fever. Well, if you go into details and phenotypes those patients, there are patients without symptoms, of course, no symptoms outside the pollen season. There are patients with mild symptoms, which you could get rid easily with an oral antihistamine, but there are also patients with severe discomfort, with many symptoms in the eyes, in the nose, with a strong impact on the quality of life. And these are the patients with therapeutic needs. So allergen immunotherapy is not for the patients with a very easy respiratory disease you can get rid with antihistamine. So in that survey, we asked them, have you seen a doctor over the last 12 months? The answer is no in 50%. So 50% of the patients have mild symptoms and they can, with over-the-counter antihistamine or medication taken from the family, easily have relief. 50% of the patients had a consultation, mostly to their primary care physician, and 70% of these patients were okay with pharmacotherapy. But it means that 30% were not controlled. So these are the patients which we target with allergen immunotherapy. So a third of the treated patients are not controlled. It means that 1/3 of our treated patients are escaping from the current drugs we have. And these third actually are the ones which bother us the most. And there are so many data showing that allergic rhinitis could bother. This is one coming from the US. What they calculated is amongst more than 8,000 employees for more than 47 companies. They calculated the yearly cost of chronic disease, for 11 chronic disease, from coronary heart disease here. And you can see here in US dollars that allergic rhinitis in the US costs the most, $593 US, even more than asthma. You can see here asthma. And arthritis and other disease in these patients going to at work. So allergic rhinitis is not a trivial disease. But we allergists or pulmonologists or ENT doctors, I mean specialists dealing with respiratory diseases, actually we are seeing the most severe patients. And in that particular survey performed in allergy practices in France, you can see that 80% of the patients were severe. So most of the patients didn't have a mild disease. So we have very severe patients coming to our practices, and you can see that usually they come late to our practices. They come in a mean of 5 years after complaining about their severe disease. So 5 years retained by their GP, not sending them to a respiratory specialist. So in Europe, just to give you an example, 1.5 million patients are under allergen immunotherapy last year, and you have here some numbers you may need to know, and you can see where are the biggest markets. So Germany, 500,000, that represent 3.3% of the patients with allergic rhinitis. France, where I come from, 350,000, which is 2.3% of the patients with allergic rhinitis. So it's always less than 5%. So you can see that there is room for improvement. So allergic rhinitis is not a trivial disease. We, as respiratory specialists, see the most severe patients. So we have to offer them more than a GP can offer. Otherwise, they could stay and see their general practitioners. So the second dogma I'd like to talk to you about is allergen immunotherapy has never been properly tested. There are so many doctors saying that. Well, even though allergen immunotherapy is widely prescribed, the lack of proof of efficacy persists in the people actually not reading the literature. But the health agencies, actually, they do read the files and they do acknowledge that allergen immunotherapy work because they register the product. And you know, a product which is registered means that it has efficacy. And for example, in Europe, the European Medicine Agencies has issued guidelines on clinical development of allergen immunotherapy in allergic rhinitis. And in these guidelines, the companies have to show the same level of evidence as other pharmaceutical products. It cannot be below the requirement for any other pharmaceutical product. So if you compare, for example, the development of Oralair, which is the 5-grass allergen immunotherapy tablet, which has been launched in many countries recently by Allergen, if you compare that with something you would never doubt about the action, Avamis, which is the GSK in local steroids, you can see how it was developed, both in allergic rhinitis. And you can see that the Avamis performed 3 phase 3 studies, and there were 4 phase 3 studies for Oralair. You can see the number of patients, even more with Oralair. You can see the primary outcome, only 4 symptoms for Avamis and 6 symptoms for Oralair. And you can see how many days it was assessed for Avamis, 2 weeks, compared to the entire pollen season for Oralair. So none of you would say that Avamis does not work, I guess. And none of you would imagine that Avamis has a weak development. It has a strong development, but Oralair has as good development as Avamis. And if you pull together Oralair and Grayzax, which are the 2 products for allergic rhinitis due to grass pollens, you will see that there are 12 phase 3 studies, almost 7,000 patients included in the program. So the dogma according to which allergen immunotherapy has never been tested is completely wrong. The development is as good. Well, if you now go a little bit more into other allergens like house dust mite, sublingual immunotherapy, coming from small randomized controlled trials. This is a meta-analysis of small randomized controlled trials. I guess you have seen that kind of data previously. So you see the treated patients and the placebo. So all of these are small studies, but you can see that the effect size, the diamond at the bottom, you can see that the effect size is really good, 0.97. And this is the starting for the development of a tablet on allergen immunotherapy due to house dust mite. And this is the current development, both by Allergen and ALK. You can see that there are phase 1, phase 2, and phase 3 now studies ongoing on asthma. Here, the 2 companies has phase 3 studies on allergen rhinitis in Europe, and they also have partners in the US and in Japan to perform the same studies in the different diseases. So you will have, as we have strong data for grass pollen, you will soon have strong data, and I'm going to give you some of this data actually. Some are already disclosed, and you'll see that it is also effective in house dust mite-induced respiratory diseases. So the third dogma, according to which allergen immunotherapy is less effective than pharmacotherapy, comes from small randomized controlled studies performed up until the year 2000. You know, all these small studies with different results going everywhere, and only meta-analysis shows that there was an effect. But a full development program was needed to prove that effect. So even though it is impossible to perform a direct comparison, if some of you want a direct comparison between allergen immunotherapy and pharmacotherapy, is technically impossible. It is clearly shown, and I will give you the data, that the symptomatic medications appear to be less effective in releasing symptoms of allergic rhinitis, and this comes from large systematic reviews. I just want to make a little parenthesis here to show you that nasal steroids usually are developed using nasal symptoms, blocked nose, runny nose, itchy nose, and they usually don't use high symptom. Antihistamine, they can use the 4 nasal symptom and the 2 high symptoms, but usually they don't use the nasal obstruction symptom. For allergen immunotherapy, the 6 symptoms are developed. And this is something tricky. If you have already performed clinical trials, you understand what I mean. So you can really change a little bit the results if you don't use the symptoms which you are not planned to be effective on. Like antihistamine, you don't use the nasal obstruction because you think that you are not going to be very active on nasal obstruction. There is something you really need to understand when you develop a product of allergen immunotherapy, is that patients are included before the pollen season. It's different from nasal steroids and antihistamine, where the patients are included at the peak of the pollen season. And you never know how the pollen season is going to be. And if I take the example of this long-term survey from Graysax, you can see that the year where the patients were included is here, and then that was the second year and the third year, and 1 year after stopping the treatment, and 2 years after stopping the treatment. And for reasons nobody could control, apart from God, is that the number of pollens decreased over the Therefore, you understand that the patients will have weaker symptoms. Okay? So this is something with long-term studies that you can't really control. And I just want to explain to you, I'm sure you're familiar with that. This is a pollen season, which is roughly 30 days. And you include the patients 4 months before the pollen season for allergen immunotherapy. For antihistamine, you include, as I said, the patients at the peak of the pollen season. And you have on the left-hand side the symptom score, right? When you do that, you can see that the mean for placebo in nasal steroid antihistamine is higher than the mean for placebo for allergen immunotherapy, because you have to take into account 4 weeks versus 2 weeks. So although there are these technical differences that you can go around, you just need to have a large study with a placebo group every time. Even though there are these really differences between pharmacotherapy and allergen immunotherapy, you'll see that the effect size is strong. So in order to show you that, I took 2 systematic reviews. This is the one from Benninger, 38 studies on rhinitis, including almost 1,300 patients, and analyzing antihistamine and nasal steroids, and also another meta-analysis of 4,000 patients. So you see these studies. So it's more than 50 studies. You can see on the right-hand side the duration. 2 weeks is enough to have a nasal steroid on the market. And you can see here at the bottom the development of Orale and Graysax, the number of patients, the number of studies, and the number of the days, 40 days versus 14 days. And here are the results. I don't know if you are aware of that, but antihistamine give you an effect roughly 10% over placebo. Look at the right-hand side column. 9% over placebo, 7 to 9% over placebo. Nasal steroid will give you an effect which is 17 to 26% over placebo. All right? And in the Orale and Graysax, you have 30% over placebo. And in the most severe patients, which I will show you, it's 30% over placebo. And you know that the placebo effect is huge in respiratory allergies. So you already have a 30% placebo effect, plus 40. That means that you have effects on 3/4 of the patients. And this is not something you can see with nasal steroid. So the people in the room who would raise and say nasal steroids work better, I just want to show the data, them to show the data. Okay, this is something very interesting. If you take if you reanalyze the Allergen Orale study and split the population into 2 groups, the one with low symptoms, middle symptoms, and very high symptoms in the placebo, you can see that the effect size is even bigger in the patients with the higher symptom. You can see here a huge effect size, 34. I told you it's 10% for antihistamine, and it's 25-30% maximum for inhaled steroids. And you can see here the effect with allergen immunotherapy for grass pollens. This is another way of showing it. This is the Graysax development. You can see here the placebo here, and you can see at the bottom the effect of immunotherapy. And from left to right, you have the pollen counts. What you see here is that the 2 curves separate from left to right. You can see that the distance between the two curves is higher on the right-hand side when the pollen counts are high compared to the left-hand side where the pollen counts are low. It means that the more severe the patients are, the more efficacious is allergen immunotherapy. It is exactly what we want. We want to target the most severe patients. We don't want to target the mild one. And these are the first data. It's in press in the Journal of Allergy and Clinical Immunology. I told you that there is a full development for house dust mite tablet. This is the first data for the Stalogen tablet on house dust mite. Is a mixture of Dermatophagoides pteronissinus and Farinae, 50-50. And the patients were included for 1 year. So the gray line is the placebo. This is the symptom score adjusted with treatment. And you can see that the placebo always goes better. This is the first year. Then the treatment was stopped, and the patients were followed for 1 year. And you can see the blue line differentiating from the gray line rapidly as early as month 4, with a strong difference between with the placebo, which was maintained over 1 year. So you can see here that house dust mite allergen immunotherapy for allergic rhinitis does work, and it works fast as early as month 4. Well, I just want to give you one data on asthma. This is a Chinese study. It is a steroid-sparing study. House dust mite sublingual immunotherapy drop performed by Stalogen. The patients were controlled. Steroids were lowered down till uncontrolled, and then they were put on immunotherapy, and then they were followed up for 1 year. And you can see that for the total population, in terms of steroid sparing, there was a small sparing which was not significant, but when we split the data with GINA 2 and GINA 3 patients, you can see that in GINA 3 patients, there was a reduction here of the mean inhaled steroid per day used by 38%. 38% over the placebo. And if you analyze this data in terms of control, there was a better control, well-controlled and total control here in gray compared to placebo in green in the most severe asthmatics, in the moderate persistent asthma. So this is something which goes against what we were used to. We were used to prescribe immunotherapy before asthma was too severe. This study shows that when asthma is more severe, allergen immunotherapy works more. This paper is in press in JACI as well. So let's talk about the Dogma 4. Allergen immunotherapy must be taken several years to be efficacious, 3, 4, 5 years, and therefore patients will not wait that amount of time. And from the house dust mite data, I showed you that the onset of action was really short, 4 months, so we don't need to wait 5 years. We know immediately when allergen immunotherapy is efficacious. We know that it is efficacious immediately after the first season, so 1 year is enough to wait, and there are many data showing it. This is the data from Stalogen, the long-term study. The patients were treated by either placebo or oral air, 300 IR, 4 months or 2 months before the pollen season, then during the pollen season, then stop, then restarted the year after, and stop, and restarted the third year, and then stop for 2 years. So it's a 3-year study, then 2-year follow-up after stopping. And you can see that the effects is obtained immediately after the first season. You don't need to wait 5 years. You know rapidly, because it's more expensive than pharmacotherapy, but you know rapidly if it is efficacious or if it is not. And nicely, you can see that this is the promise of allergen immunotherapy I haven't talked about yet. That may be the questions. Is the promises of immunotherapy is that when you stop the treatment, it's still efficacious. That's what we are expecting. And this is proved here. 1 year is also proved for the second year. Has been proved also by ALK. So now we have strong data with registered products that shows that it is quickly efficacious and with a sustained treatment after stopping the drug. So we can even do some neater study, and this is a particular study where the patients were actually challenged by grass pollen. They were put in a room and ventilated with pollens outside of the pollen season, and then you just put them on placebo or oral air, and you do challenges whenever you want. So you can do a challenge after 7 days, a challenge after 30 days, so you can challenge after 2 months, and after 4 months. So you see the design here. What you are looking at here is the onset of action. And you can see that this is the placebo and this is the treated group, and you can see that as early as week 1, you already have a difference between placebo and treated group, but not significant. This difference is significant after month 1, and the significance is maintained over the 4 months of the study. So you can see that the onset of action is really quick, and is not 3-5 years as we might have thought before. So the fourth dogma is wrong. So how about the fifth one? Allergen immunotherapy does not work in polysensitized patients. This is what it was written in guidelines. For example, in this guideline, allergic rhinitis and its impact on asthma. But since then, many rigorous clinical trials have been performed assessing mono versus polysensitized patients. And I'm just going to give you the post-hoc analysis of the Allergen adult study, and you can see results in monosensitized, polysensitized, both in placebo and treated group. So here you have the effect in monosensitized. From 5 to 4, there's a reduction, and you have the effect in polysensitized patient. So the effect size is exactly the same in monosensitized and polysensitized patient. Has been found the same results for Gray-Sachs. Therefore, the treatment effect is similar in monosensitized and polysensitized patients. And this is really important because most of our patients are polysensitized nowadays. So the last dogma is that for those of you who use subcutaneous immunotherapy, I just don't want to oppose those. They have the same principle, but I will show you that there are actually very few data showing that SCIT gives a better compliance, but it is in doctors' mind, and it is mainly in allergists' mind, actually. But we don't know how many patients fail to keep one or more appointments over the course of the year. There is no solid data. There are even data in the US in teenagers showing, and this is a data performed by the Social Security. I mean, it's one of their HMO, Medicaid, and what they have searched in that particular study, it's performed by Medicaid, it's not performed by allergists, is that at the end of the 3 years of treatment, only 16% in SCIT, 16% of the adolescents were still on immunotherapy. So what they simply did is they didn't go back to their allergist in a country where immunotherapy is well perceived. There is similar data in Germany. This is performed by the Social Security in Germany. You have here the sublingual immunotherapy and the 2 subcutaneous immunotherapy treatment. In Germany, they have natural allergens, and they also have modified allergens. And you can see the first year, the second year, and the third year. So you can see the decrease in compliance in all treatments, actually, but less in SLIT. So therefore, it's a long-term treatment, and as always for chronic diseases and long-term treatment needs to be explained to our patient. So compliance with sublingual immunotherapy is not worse than compliance with subcutaneous immunotherapy. So to conclude, allergic rhinitic patients do not all have the same medical needs. There are patients with mild symptoms and patients with very severe symptoms resisting pharmacotherapy, and it's almost a third of the treated patients. Allergen immunotherapy addresses the needs of these patients, actually the one you are seeing in your consultation. Thanks to a clinical development program that meets the top requirements of the different regulation agencies, in particular the European medicine agencies, but I can tell you that the Food Drug Administration is following very closely what is done in Europe. has been shown that the efficacy of allergen immunotherapy is unambiguously demonstrated. The large studies performed have provided a better understanding of allergen immunotherapy, and I didn't talk about mechanism, but we know now how allergen immunotherapy works and have facilitated the application of evidence-based medicine to this particular therapy. We know the onset of action, which is short. We know that it is efficacious in monosensitized and polysensitized patients. We know that it's highly efficacious in allergic rhinitis. And I didn't talk about side effects, but it's almost trivial. Very mild and short-lived side effects. And we know that it does work in pre- and co-seasonal treatment. So despite recent progress in understanding allergy and the standardization of products and regimen, allergen immunotherapy is still hindered by a number of fallacies and misconceptions. And it's my understanding that you had a pro and con session yesterday, which was tough. I hope the pro leader won. Where is Dr. Zitoun? These false beliefs are no longer justified. I mean, the people with false beliefs are actually the ones who don't use immunotherapy. We have entered the second age of allergen immunotherapy with robust clinical trials and rigorous evaluation of products for registration. These products have to be all registered one after the other, and not allergen immunotherapy as a bulk, but every single product has to be registered. Allergen immunotherapy is moving from experience and dogma to evidence-based medicine and facts. And we, allergy specialists, either full allergy specialists or organ specialists interested in allergy, can accelerate this process by applying the principles of evidence-based medicine in our daily practices, and thus contribute to the coming 100 years of immunotherapy. I thank you for your attention.
Merci beaucoup, Pascal, pour cette excellente présentation. J'espère qu'elle a pu convaincre toute l'audience de l'intérêt de l'immunothérapie. Des questions, s'il vous plaît.
Excuse me, is there any study to show the difference between Xolair and immunotherapy?
There are studies on using Xolair on top of subcutaneous immunotherapy, because the problem with subcutaneous immunotherapy is that we have a high level of side effects, as you know. We have bronchospasm, and we have systemic side effects. We have anaphylaxis, actually. So there are nice studies on in order to prevent, but not in parallel. It's on top. Okay.
So can we use instead of immunotherapy? Can we use Xolair instead of immunotherapy? That's my question exactly.
I think Xolair, for the time being, has very specific indications at the very right-hand side of the GINA step 5 part. But in these patients, we almost have nothing in these very severe asthmatic patients. So there are teams who actually use both. They use Xolair for these patients, and if still they have symptoms when they are exposed to allergens, because some have symptoms without being exposed to allergens, but some are really, truly allergic asthma on top of their very severe chronic persistent asthma, and they try, especially in children actually, and they add on top of Xolair, they add allergen immunotherapy. And most of the time it's house dust mite. But that would make the treatment very expensive. But anyway, these patients have nothing else. Oh, yes?
Thank you, Dr. Demoli, again for participating in our Congress. I have two questions. First is the polysensitized, monosensitized, because for non-allergists, this can be a little bit confusing. From what I understood, even if we treat for 1 or 2 pollen, we can still have benefit. We don't have to mix a lot, and this is like a practice that we have to mix a lot, which I think is not useful, but you can correct me. And my second question is about immunotherapy to mold efficacy, in particular penicillium or cladosporium. Thank you.
Thank you very much. Dr. Irani. These are two very good questions. In order to prove efficacy, these patients could be monosensitized and polysensitized in these studies, but they could not have symptoms, they could not be exposed during the evaluation period. Otherwise, you don't know what you evaluate. So they could be polysensitized, but not to something which was present during the grass pollen season. Otherwise, that would completely mix up the... for example, they could not have a cat at home and be allergic to cat and keep the cat during the pollen season. Otherwise, we wouldn't have been able to capture the effect of the treatment. So you are right. As an allergist, we often have patients allergic and sensitized, exposed and allergic to several allergens, and therefore we have to maybe perform several allergen immunotherapy. In terms of development, it is impossible. It's not receivable. It's impossible for an agency to, at this stage, to accept a mixture, because every single compound for the most relevant allergens have to be evaluated. Having said that, the good clinical practice, what is done currently, is to use separate allergens most of the time. That's what we are actually pushing the allergists in France to do, not to mix, because in terms of pharmaceutical stability, whenever you mix something and you keep that something for several weeks, you don't know what's in it in the end. There are doctors mixing molds and hazardous mites with pollens, and we know that it is absolutely not a good practice for sublingual, because those allergens actually, they eat each other. These most are enzymes, so they can denaturate the other allergen. So I would say that we need first to validate one by one our products. This is a requirement from the registration agencies, and maybe later on test mixtures. But for the time being, we don't have data on that. There are countries mixing, like the US. The US, they mix a lot. The mean of 8 allergens per injection. In Europe, we very little mix. So I don't know in your country if you mix a lot. So in terms of there's just no data. That's what I'm saying. I'm not saying it's bad. I'm just saying that it's not evaluated. In terms of mold, same. Very little data on mold allergy. There are papers, several. Adnan has offered one of them, but. It's a very difficult allergen to produce, actually, to produce of very high quality, because it has to be a very high potency, and we are lacking data for molds, I think, I would say.
Short question, short response, please.
Yes, please. Is there any point of continuing with immune sensitization if the patient shows no response after 1 year?
No, I don't think so. If compliance is okay, if you're sure that the patient has taken the treatment, if there is no comorbidities you have missed, something you have missed in his or her environment, there's no reason to carry on.
Okay, s'il vous plaît. Victor.
Jusqu'à quel âge on peut commencer une immunothérapie dans l'asthme et dans la rhinite allergique? Okay. Jusqu'à quel âge maximum?
Maximum.
Yes.
It's not so how late you can go and start immunotherapy.
Yes.
That's right. Really, immunology is we've seen. All right, I live in the south of France, Montpellier, where we have cypress pollens, and these cypress pollens, they don't exist in the northern part of France. So the people living in Paris, they sell their little studio and they can buy a full house in Montpellier for the same price. And when they arrive at the age of 65 in Montpellier, they first, if they are atopic, they first encounter cypress pollen. And within 1 year, they can become severely allergic to pollens. And we start immunotherapy in these patients, and we don't take into account the age. We take into account the duration of the disease, actually. They are topic, but they were not exposed to cypress, so they were not allergic to cypress when they used to live in Paris. But once they moved to the south of France, they became very severely allergic. So we know that it is better to start early, has been shown, and Nan has shown that too. The earlier we start, the better. But we have very nice successes starting late as well.
Dernière question. Faris, tu as une question?
Yeah, thank you, Pascal, for defining these dogmas and shedding some light on it. I go back to the monosensitized, polysensitized issue. You know, I come from the U.S., and you know we are pro-polysensitized. Now, I think there's always this controversy between Europe and U.S., and I think now, for the first time, maybe we're getting a little bit closer, especially with showing that even single therapy for a polysensitized patient seems to still be effective. However, a recent analysis published in JACI, I don't remember which year it was, showed that it is still less effective than if it's a single sensitized patient. It was analysis on, but the problem is there's very few sublingual studies done on single treatment in polysensitized patient. The effect was their effect, but less so than if it was just a singly sensitized patient. As far as the polysensitized issues, in the US, you know, this is the practice. It's been the practice for 50, 60 years. I think and I always say it's a technical issue. In the US, the way that we make our extracts, the way we mix things, we make sure they don't have proteases that will knock down each other. We don't mix moles with certain things. And when we put the allergen, we put it in such a way that the exact amount does not get diluted. The problem with sublingual immunotherapy, one of the problems with it for me, for polysensitized patients, is technically speaking, when you mix things, they become more diluted. And therefore, you're not going to get the highest effective dose. And this is, I think it's really more of a technical issue between the European and the American, based on the way they mix and the way they treat.
Faris. Réponse rapide, s'il te plaît.
I think whenever you mix, wherever skit or slit, you dilute. And what has been shown in phase 2 trials is that low dose doesn't work and high dose work. Therefore, there is a risk of diluting and hitting the wrong dose. In these trials I showed you, 100 IR is ineffective. 300 IR is effective. So it's very tricky. So we have really to pay attention to this dilution thing, what is left afterwards.
Merci beaucoup.
If you are able to dilute and keep the same concentration for each allergen.
Yeah, I agree. No, I agree, but not all the allergies do that.
I think we should continue this conversation over coffee. We have coffee outside.
On a commencé 30 minutes après. Merci beaucoup. Merci Pascal pour cette présentation.